Hey students, it's Dr. Ways, and welcome to your lecture on the scalp and cranial cavity. So we'll begin with the scalp, and the scalp actually has 5 layers to it, and they're named so that they actually spell out the word scalp. And so from outer to innermost layers, the first would be the skin, all right, up on top, and you can see that over here on the right. The second layer would be connective tissue, specifically dense connective tissue, so you know that it's going to be really tough connective tissue that's going to hold things together. 3 would be our aponeurotic layer, and remember, aponeuroses are connect muscle to muscle, so you're going to find it between your two muscles, or your muscles in the forehead and that which is in the back of your head on the occipital region, and we'll talk about those when we get to the muscles of facial expression. The 4th layer is our loose connective tissue layer, and the 5th layer is our pericranium. All right, 5th layer, pericranium, right here, and that's sitting right on top of the bone. It's basically the periosteal layer. So going into a little more detail, we'll look at the first 2 layers, our skin and connective tissue. Remember, the skin itself has the epidermis and the dermis. So it's going to be similar to everywhere else in the body, with one special feature, and is that it has hair around the entire area. All right, so that's going to be one exception, because we don't have hair on all parts of skin throughout our body. So that's a unique feature. And the connective tissue underneath it, this dense connective tissue you see right here, that's going to contain a lot of nerves and blood vessels to it, nourishing the dermis and the epidermis. Okay, I lied. The aponeurotic layer is this right here, the 3rd layer in, and it's between a set of muscles that are collectively called the occipitofrontalis, but separately there'll be the epicranium frontalis and epicranium occipitalis right here. So this aponeurosis would be connecting those 2 sets of muscles, and its job as those muscles' job is to basically raise the eyebrows up. So this epicranium, or epicranial aponeurosis, would allow the muscles in the occipital region to contract, pull on the aponeurosis, and raise our eyebrows from the back. And I'll show you in lab how you can actually feel this yourself. The muscles that this is between are innervated by the facial nerve, cranial nerve 7, specifically the temporal branch. All right, so the other action that this does is it actually lets you wrinkle your forehead. So raising your eyebrows and wrinkling your forehead is the action of both the occipitalis and the frontalis. All right, the last 2 layers are the loose connective tissue layer and the pericranium. So the loose connective tissue layer, as it says here, facilitates movement of scalp over the calvaria, so movement of the scalp over the skull cap. So if you take your hand and put it on your head tightly and then move around, you can feel the scalp moving around over the skull. And so that's because of what's going on in the loose connective tissue. All right. One of the features of this, though, is that blood and fluids can accumulate in this area due to the connections between the dural sinuses and channels between it and the loose connective tissue through the bone, through the skull. All right, these are called emissary veins. All right, these emissary veins right here that are going from the dural sinus to the loose connective layer. And often the loose connective tissue layer, the L layer, is called the danger layer. And the reason it's the danger layer is that if, let's say, you have an injury in your head right here, and this blood is connected, and you get an infection, because of the fact that this blood vessel is connected to the dural sinus, you could end up with an infection within the dural sinus that can then spread to other areas of the head, and if it's bad enough, can destroy the meningeal layers and even get into the brain. So, really bad thing. That's why it's considered a danger layer. All right, the pericranium, let's get rid of red. The pericranium is the last layer, and I know it says here it's the outer layer of the bone, so it's the innermost layer of the scalp, but the outermost layer of the bone, and it is the periosteum of the calvaria, of the skull cap. So it's that layer of bone, thin layer of tissue over the bone that is involved in creating new bone. All right, so it's a very important bone making layer. All right, so now we're going to move to the skull. So we've already covered everything in the scalp here, and notice there's an overlap here between the scalp and the skull. All right, and that is the pericranium, all right, or the P layer of the scalp. And then we get into the actual bone of the head, and that is the structure is right here. It's a membranous layer of bone. So intramembranous ossification is how it would form. And the structure is that it has an outer layer of compact bone, then it has a layer of trabecular bone, which is called the diploe, and then it has an inner layer of compact bone, and the outer layer and the inner layer are called the outer table and the inner table. All right, for the nerve and blood supply to the scalp, we'll do the blood supply first, and we'll do that in red. The blood supply is going to come from two sources, and you'll see that the nerve supply is going to come from two sources as well. The anterior blood supply, going this direction, is supplied by the internal carotid artery. So there are branches of the internal carotid artery. So you don't need to know the branches, just know that those anterior branches come from the internal carotid artery. And from the posterior is from the branches from the external carotid artery. So anterior, internal carotid artery, posterior, external carotid artery. And remember, the internal carotid artery is also what's supplying the structures inside of the skull with a blood supply. All right, for drainage, we have these vena comitantes for drainage, and remember that is the arrangement of veins that are two smaller veins on either side of an artery. For the nerve supply, we have a very similar setup. So anterior innervation comes from cranial nerve 5, otherwise known as a branch of the trigeminal nerve, and we'll talk about that when we get to later on when we talk about cranial nerves. And then the posterior innervation, okay, so in general you see all of these different branches here. You don't have to know the different branches, you just have to know that the anterior innervation comes from the cranial nerve 5, the trigeminal nerve, and then the posterior innervation comes from cervical spinal nerves. So various spinal nerves from the cervical region. One thing I want you to notice with the blood supply is that we have the arteries coming from anterior and arteries coming from posterior, but they all interconnect with each other. And as we've seen in other areas of the body, the reason why we have these anastomoses is that, let's say, the external carotid artery is compromised somehow on the right side, well then the internal carotid artery can still supply blood to the scalp in the absence of what's coming from the external carotid artery. All right, now we're moving on to the meninges, and we've already talked about the meninges when we did the spinal cord, and they're no different for the brain, which is the organ that's inside of the skull. So the outermost of these meninges is still going to be the dura mater, and that's going to be that really tough connective tissue layer. But the arrangement is a little bit different. So you have actually two layers of dura here. One is the endosteal dura, so that would be just underneath the bone, just underneath the skull, all right, which I'm highlighting in green here. And then the other layer is going to be the meningeal dura. All right, and so that would be this layer here on the inside. And you notice that the meningeal dura goes between, so it's between the endosteal dura and the other layers of the other meningeal layers, and it goes between the brain, so it dives down and goes between parts of the brain where you have separations. All right, so for example, between the cerebral hemispheres. All right, and then what it also allows you to do is form venous sinuses. All right, so venous sinuses where blood collects as fluid is draining from the brain. All right, so the venous sinuses are going to be between the dural layers. And so down here we see the spinal cord and the dural mater, and then it going into the brain and showing the continuity of the dura mater. And notice it's only one layer in a spinal cord. The second layer is actually coming from the bone. All right, so it starts there with the bone and goes along the inner lining of the skull, whereas the meningeal dura is going to come directly from the spinal cord. So the dura mater in the cranial cavity is going to be pretty complex. There are several folds that are within the cranial cavity that separate the brain really into different compartments. All right, and the ones that we're going to talk about, one is going to be the falx cerebri, and that's going to be this dural layer that invaginates between the cerebral hemispheres. We have the falx cerebelli, which is a dural layer that's between the hemispheres of the cerebellum, so it separates the two cerebellar hemispheres. We have the tentorium cerebelli. All right, so what do you think that separates? The cerebrum from the cerebellum. And then we have the diaphragma cellae right here. So you notice that's in the sella turcica. You can really see this, and maybe I'll pull this out in lab if I can talk to the science department to borrow a sheet brain. When we get sheet brains and we take the dural layers off so we can see the brain itself, there's often this hard little membrane that is at the base where the pituitary gland is, and so that's going to be this diaphragma cellae right here. Really tough spot that's, one, going to hold the pituitary gland in place and separate it from the brain structures that are in the diencephalon. And then here on the right we see these dural folds with brain tissue taken away and what it would look like in a real skull. The blood supply to the dural layer comes from the external carotid artery. So here we see the external carotid artery coming up, and then it's going to branch into what we call the middle meningeal artery. Which is then going to further branch and go to all regions of the skull to supply the dural layer with blood. And if you look at the calvaria when you take it off, you should be you'll usually be able to see impressions of the branches of the middle meningeal artery showing you the blood supply to the dural layers. All right. Another feature that you'll be able to see in the skull are these little granular foveolae or foveolae. And these are from arachnoid granulations that whose purpose is to drain cerebrospinal fluid and return it to circulation. One thing I want to caution here, though, is right now we're talking about the middle meningeal artery. And remember, that goes along the skull and supplies the dural layer with blood. Do not mix this up, and you'll get this again later when we cover this artery. Do not mix this up with the middle cerebral artery, which is going to supply the brain itself with blood, or areas of the brain. So make a note of that now, not to confuse this artery with the middle cerebral artery. The other thing I want to mention on this slide is related to these down here. If you stretch or crush the meningeal arteries, that can cause a headache. So, usually we think of our headache, oh, my brain hurts. No, actually, it's lack of blood flow to the meninges that is the cause of headaches, because the middle meningeal artery is very, very sensitive. So any kind of occlusion or damage that comes to that, or increases or decreases in pressure, will aggravate the middle meningeal artery, thus leading to a headache. All right, so continuing on with the dural layers and talking more specifically about these dural venous sinuses, their function is to drain all the blood and all the absorbed cerebrospinal fluid from the brain. So you see these cerebral veins right here. They will drain and then empty into these dural venous sinuses. And these dural venous sinuses are going to be collection spots for this blood that will eventually get drained into the internal jugular vein. Remember, that's that great big vein that's in the anterior triangle of the neck. So it turns out there are several dural venous sinuses. So the one you saw in the previous slide is probably the superior sagittal sinus. At least that's what it looks like. So that superior sagittal sinus is this one that's running right up the middle here, superior sagittal sinus, and that makes sense because it's all the way at the top and it is running along the sagittal suture, really. Then we also have the inferior sagittal sinus, because remember, the falx cerebri divides the left and right hemispheres, but there's still a diencephalon which is not physically divided. So this is going to run over the diencephalon right here, and that's going to be our inferior sagittal sinus. All right, those two are connected to each other through this straight sinus. All right, and in the back, where you have connection of a multitude of sinuses, is our confluence of sinuses. So confluence means a coming together of things. So many of your dural sinuses, our dural venous sinuses, are going to come to that point. All right, that will include our right transverse sinus along with our left transverse sinus that you can't see here. And notice that's running along the tentorium cerebelli. And then we have our sigmoid sinus, which is this S-shaped sinus running along the base of the skull. And you can see that other one down here, sigmoid sinus, has kind of a curvy shape to it. And they're going to come up and connect to this cavernous sinus. So you see this cavernous sinus that's just draining other parts of the skull, not just what's in the brain. So you see these branches coming from here. You don't have to worry about those. And then we have our intercavernous sinus, so between the two cavernous sinuses, that are going around the pituitary gland, around that diaphragma sellae right here. All right, so all of those are draining different parts of the, collecting fluid from different parts of the brain and CSF, and all of it's eventually going to dump into the internal jugular vein. So if you look up here, this is another picture, looking right here, of what the cavernous and intercavernous sinuses would look like. All right, also note that these are dural venous sinuses, not to be confused with sinuses that are within the maxillary bone that have different functions. So those aren't filled with venous blood, whereas these dural venous sinuses are filled with venous blood. All right, these are just different views of the sinuses. So we didn't get a good look in a previous picture of this transverse sinus right here. So that would be the same as this. And then the sigmoid sinus, we can see that S shape. We can see that curve as it's going up to connect with the cavernous sinus right here. And then on this picture right here, notice that here are our internal jugular veins, and they are going to connect with the sigmoid sinus right here and go through the jugular foramen to the internal jugular veins. All right, so the next layer would be the arachnoid mater, and that would be this dark green layer right here. And then under that you have the subarachnoid space, and all of this is going to be filled with cerebral spinal fluid, and we'll talk about the flow of cerebral spinal fluid at some point when we're talking about the skull, or I'm sorry, the cranium and the brain. All right, and then here are these arachnoid granulations right here. So here is where cerebral spinal fluid would go into these arachnoid granulations and then come out of them into the dural sinuses to get that cerebral spinal fluid, or what the cerebral spinal fluid needed to get rid of, back into circulation. All right, and it's these arachnoid granulations that are sitting in certain spots. So let's say there's one right here that would be sitting in a spot and make that impression within the skull that we saw. All right, and just underneath that, between the arachnoid layer, underneath the arachnoid layer and the subarachnoid space will be this red layer right here, and that would be the Pia Mater. All right, and that is directly on the brain, sitting on the surface of the brain, highly vascularized, and an entry and exit point for blood vessels within the brain. And those blood vessels from the brain come from this structure that is really important to the circulation of blood to the brain, called the circle of Willis. And the circle of Willis is this circular pattern of blood vessels, most of which are coming from carotid arteries, but a small amount coming from vertebral arteries, remember, that are going up through C1 through C6 in the neck. That, like many other spots where we saw connections between arteries, allows for continuous circulation of the brain, even if one side happens to be compromised, or one particular artery happens to be compromised. So looking at it here, here's the circle of Willis as it sits within the brain, and notice that it sits around the optic chiasma. All right, so it's literally circling the optic chiasma. And over on this right side, here is the aortic arch, and then we have our left common carotid artery, right common carotid artery, and then our right internal carotid, left internal carotid, and here are our vertebral arteries coming up. So the carotid arteries come in and form the outer basis of the circle of Willis, and then the vertebral arteries come in and form the posterior portion of the circle of Willis by becoming the basilar artery. All right, so we'll go through this circle in the next couple slides. All right, I kept this picture right here so that you could see the whole thing in as it sits in the brain in vivo. But over here is a picture from your bare bones book that will show you how everything is connected. All right, so here are your vertebral arteries coming in from the back, and they form our basilar artery right here. And here's our internal carotid arteries coming in from these sides. All right, so this basilar artery will then split off and become the posterior cerebral arteries, left and right, which will then have a branch called the posterior communicating arteries. So from the posterior cerebral arteries come the posterior communicating arteries, which communicate with the internal carotid arteries and form the middle cerebral arteries. All right, so we have the posterior cerebral, the middle cerebral. The middle cerebral has these the anterior cerebral arteries coming directly off the junction point between the internal carotids and the middle cerebral, going to the front. And then there's this anterior communicating artery that connects both anterior cerebral arteries as they're going to the anterior portion of the brain. So this anterior communicating artery and these posterior communicating arteries are what actually form the circle and allow the major blood vessels that are going to the brain to communicate with each other. So let's say, for example, that you are compromised with your one of your carotid arteries right here. All right, that's compromised. Blood flow will still come from these directions because you have the circle to make sure that the middle cerebral artery still has some blood going to it so that that part of the brain can get at least a somewhat adequate blood supply. All right, so I left this picture in here, which is also from your bare bones book, to give you a practice. So use this picture to practice labeling the parts of the circle of Willis and see how you do. And then this strokes right here is going to refer to the next slide. Okay, so what you're missing here with strokes is actually the word strokes, because that's what we're going to be talking about. Remember, strokes are when you have a lack of blood supply to a part of the brain due to any number of reasons, whether it be usually involved with occlusion of an artery. Okay, so the other thing that's missing are the X's. So if you have a compromise in your blood supply to one of your anterior communicating arteries, what you're going to see is contralateral leg weakness and sensory loss. All right, so if this is the left side, you're going to have leg weakness on the right side. Why? Because remember, the left hemisphere of your brain controls the right side of your body due to that decussation of these nerves that we talked about, both sensory and motor. All right, so if you have a stroke in the left side of your brain, the right side of your body is going to be affected, and that's what we mean by contralateral. All right, if we have a stroke in, let's say, the middle cerebral artery, and just to back up for a second, middle cerebral artery, don't mix that up and call it the middle meningeal artery. Remember, I told you about that in a few slides back. Don't mix up the middle meningeal artery with the middle cerebral artery. The middle cerebral artery refers to the brain. Middle meningeal artery refers to the meningeal layer, dura mater, between the skull and the dura mater. All right, so if you have a stroke in the middle cerebral artery, that will result in contralateral loss of sensation and motor control to the upper body. Why? Because the middle cerebral artery is going to supply blood to the area of the brain associated. It's going to run along the primary motor cortex and primary sensory cortex, where you're going to have upper body control. So those areas associated with the upper body. And so that's why you'll have loss of the upper body, and a stroke in the anterior cerebral artery is going to be associated with leg weakness, because it's going those arteries are going to supply blood to the areas of the primary motor cortex that are associated with the legs rather than the upper body. So the other problem that you'll see with stroke in the middle cerebral artery is specifically the left middle cerebral artery are speech problems, also known as Broca's aphasia, because the middle cerebral artery also supplies blood to that area to Broca's area in the brain, and we'll see where Broca's area is when we start talking about the brain. So you lack blood supply to that area, and the left hemisphere is the hemisphere most responsible for verbal communication. You're going to end up with speech problems. So, if a patient or a family member or a friend or somebody you see is starting to have speech problems all of a sudden, the first thing to think is, oh, they're probably having a stroke, and it's associated with their middle cerebral artery. Okay, finally, if you have a stroke in your posterior cerebral artery, that will result in loss of your visual field, specifically your temporal visual field, so that which is vision to the side, so visual loss to the side of the midline of your eye, as well as the nasal visual field on the other eye. So the way we'll talk more about that when we get to the eyes, why that would be affected, because I don't have a picture of it showed right now. We call that homonymous hemianopia. And I guess I could show it. So, here are your eyes and the way they're connected. So the posterior cerebral artery, of course, would go to the back of your brain, and that's the occipital part of the brain, and that processes visual information. And so the way it's affected is one hemisphere where you have a stroke will affect the temporal part of the eye, vision from the temporal field of vision, and of one eye, and the nasal of the other eye. So you'll be missing everything that is nasal on this side and temporal on this side. So what that creates is the side that's not affected, you'll be able to see things that are in this field, but not see things that are in this field. All right, so any vision issues then are going to be associated with the posterior cerebral artery. All right, looking at hematomas, and remember, hematomas are collections of blood in an area. So there are a few types of blood collections in the brain that you should be familiar with, and one of them is an extradural hematoma. And notice that that's mostly going to come from an arterial rupture. Like, let's say you have a fracture in the skull, you rupture an artery, and so you're going to start bleeding on the outside of your dura mater. All right, and when you have that, what that's going to do is push the brain inward. So that bleeding is going to collect, and it's going to push the brain inward. And depending on how severe it is, it might even push the brain through from one side to the other, what we call a midline shift. And that's going to be a really bad situation. That means, you've shifted your entire brain over, and there might not be coming back from that, even if this is taken care of in a relatively rapid period of time. Because remember, arterial blood flow is going to be really rapid blood flow. So this is going to be all of a sudden start shifting over. All right, another type of hematoma is a subdural hematoma. So subdural hematoma means that it's going to occur between the dural layers. Remember, there are two dural layers. One is associated with the bone of the skull, and the other is associated with the arachnoid layer. So the meningeal versus or between the meningeal and the endostele dura. endosteal dura. And notice that this is mostly going to be venous blood that's pooling, so it's going to accumulate much slower and probably, you know, just looking at this picture, not cause as much damage because of the slow nature of blood collection and pushing on the brain tissue. All right, so this picture is showing you different herniations of the brain depending on what kind of, when we say mass, we're usually referring to blood collection, but it could easily be a cancerous mass as well. And so the different types are numbered here. One would be a subfalcine herniation. All right, and that's referring to the falx cerebri. So the subfalcine herniation is pushing the brain one hemisphere to the other hemisphere under that falx cerebri right here, hence subfalcine, falx. All right, connect those two. Second type is a central herniation, where you have the brain shifting from one side to the other. And that's not only pushing one cerebral hemisphere into the other, but you're also shifting the entire diencephalon over where it's not supposed to be. All right, and the more you shift things over in this direction, not only are you compromising brain function here, but you're smashing this side of the brain as well to make room for the part of the brain that's being shifted over. All right, the third type is an uncal transtentorial herniation. So uncal refers to a specific part of the brain, and that specific part of the brain is being squeezed over the tentorial membrane, that tentorium cerebelli that we talked about. All right, so that would be herniating in this direction. So it's supposed to be part of the cerebrum, but it's being smashed down into the cerebellum. And the last part is last one is a tonsillar herniation. And you notice with a tonsillar herniation, what you'll usually see is the movement of the tonsils of the cerebellum move through the foramen magnum. So, you know, you have the part of the cerebellum moving outside of the skull. And that's definitely going to be a life-threatening condition unless it is treated almost immediately. All right, the dura mater is also innervated. All right, and the innervation comes from a cranial nerve 5, the trigeminal nerve, as well as cranial nerve 10, the vagus nerve. And you can see just a diffuse innervation of the falx cerebri here, and where the parts of the trigeminal nerve are actually going to innervate. You don't see specific nerves here. Like I said, it's diffuse, and so when these venous sinuses associated with these dural folds stretch, that can cause pain, and it's the stretching of the dural folds or the venous sinuses that actually cause a headache, aside from what we learned with the middle meningeal artery being sensitive, and that can also be a source of a headache.